We did a real-world evidence-based data analysis, which was retrospective in our institution in Vilnius, Lithuania. We compared the outcomes of MDS patients who had increased blasts 2, so from 10 to 19% of blasts in their bone marrow, and who were considered eligible for an allotransplantation, but did require a cytoreductive bridging therapy. So there were two arms. One cohort was actually bridging with Venetoclax-based therapy, so the majority of patients received VEN-AZA. One patient did receive VEN plus low-dose chemo regimen, and the other cohort was actually patients who were bridged with intensive chemotherapy, which was 7+3 or FLAG-IDA. So the groups were quite similar. The age, the fitness was more or less the same. Maybe VEN-AZA patients were slightly less fit, with more patients with ECOG 1 rather than ECOG 0. The majority of patients had high-risk MDS, both based on IPSSR and IPSSM classifications, and almost half of the patients in both cohorts had adverse risk cytogenetics. So there were a total of 18 patients who received VEN-AZA as a bridging therapy, and 15 patients in the intensive chemotherapy arm. And what we did actually see that the remission rates, the bridging to transplant rate, and overall survival were the same. There were no statistical differences in any of those outcomes. Importantly, we did see that the toxicity using Venetoclax azacitidine was lower in terms of grade 3, 4, and 5 non-hematological adverse events. Overall, it does seem that both bridging strategies did result in more or less similar outcomes, but with lower toxicity, and especially in older and less fit patients.